to talk a few minutes about obstructive sleep apnea. Lot of things can cause sleep apnea. Alcohol, sedatives, a big tongue, and anatomically uh, obstructive pharynx, hypothyroidism, like thyroid disorders, cigarette smoking. They all can cause obstructive sleep apnea. Before making the diagnosis of obstructive sleep apnea, a drug history should be obtained. A seizure disorder, narcolepsy, and depression should be excluded. Okay. So people come with sleep apnea. They usually, many of them are obese, middle-aged men. Okay. When you see these people, always think about sleep apnea. Patients may complain of excessive daytime sleepiness, morning sluggishness, headaches, daytime fatigue, cognitive impairment, and weight gain, impotence, and their bed partners usually report loud cyclical snoring, breath cessation. They see apneas, restlessness, and thrashing movements of the extremities during sleep. Personality changes can happen, poor judgment, work related problems can happen, depression, intellectual deterioration like memory impairment, inability to concentrate. So, sleep apnea can cause a lot of problems, okay? And if people are asymptomatic, you don't have to do a sleep study, but always start with physical examination. Physical examination may be normal or may reveal systemic and pulmonary hypertension with right-sided heart failure. The patient may appear sleepy or even fall asleep during evaluation. The oropharynx is frequently found to be narrowed by excessive soft tissue folds, and you may see large tonsils, elongated uvula, or prominent tongue, nasal obstruction by a deviated nasal septum, poor nasal airflow, and a nasal twang to the speech may be observed. Many of them will have a bull neck appearance. So, those are the signs and symptoms of sleep apnea. If you see the labs, erythrocytosis is common. Thyroid function tests, serum TSH, FT4 should be obtained to exclude hypothyroidism. Then there are also some tests when you see loud snoring interrupted by episodes of increasingly strong ventilatory effort that fail to produce airflow. A loud snort often accompanies the first breath followed by an apneic episode. Definitive diagnosis for suspected sleep apnea includes otorhinolaryngoscopic examination and also overnight polysomnography. Okay, so you go and sleep in the hospital or sleep center. They do a sleep study that is called polysomnography. A complete polysomnography examination includes electroencephalography, electrooculography, electromyography, ECG, pulse oximetry, measurement of respiratory effort, and airflow. So a lot of things are studied in polysomnography. It reveals apneic episodes lasting as long as 60 seconds. Oxygen saturation falls, often to very low levels. Heart arrhythmias like bradyarrhythmias, sinus bradycardia, sinus arrest, atrioventricular block may occur, and heart may go faster than normal. Tachydysarrhythmias, paroxysmal supraventricular tachycardia, atrial fibrillation, ventricular tachycardia may be seen once airflow is re-established. You can also, if you don't want to go to hospital or sleep center, you can go for a home sleep study. Okay, when there is a high test probability, you can ask for a home sleep study. While home sleep studies cannot quantify the stages of sleep, they can provide a reliable index of respiratory and desaturation events. Weight loss and strict avoidance of alcohol and hypnotic medicines are the first steps in the management. So, encourage weight loss. All right, weight loss may be curative, but most patients are unable to lose 10 to 20% of body weight required. And continuous positive airway pressure, CPAP, at night is curative in many patients. Unfortunately, you have to wear that CPAP machine, and many CPAP machines, they give you a pressure of 5 to 15 centimeters of water. Usually you can go for 8 or 9 of pressure. So you need polysomnography to titrate the CPAP to abolish obstructive apneas and manage hypoxemia. Unfortunately, only about 75% of patients continue to use nasal CPAP after 1 year. Supplemental oxygen may lessen the severity of nocturnal desaturation but may also lengthen apneas. So, supplemental oxygen should not be routinely prescribed without polysomnography to assess the effects of oxygen therapy. You can also go for mechanical devices like mouth breathers, like these devices to hold the jaw forward and prevent pharyngeal occlusion. And they have modest effectiveness in relieving apnea, but many people don't like those things. That's why they are not that successful. Surgery, uvulopalatopharyngeoplasty, UPPP, a procedure consisting of resection of pharyngeal soft tissue and amputation of approximately 15 mm of the free edge of the soft palate and uvula. So basically cutting off soft palate and uvula, creating more room to breathe. Okay, so it is more effective in eliminating snoring than apneic episodes, but this surgery may be performed on an outpatient basis with a laser. Nasal septoplasty is performed if gross anatomic nasal septal deformity is present. Another thing is tracheostomy. Tracheostomy relieves upper airway obstruction and its physiologic consequences and represents the definitive treatment for obstructive sleep apnea. However, it has numerous adverse effects including granuloma formation, difficulty with speech and stoma, and airway infection. Furthermore, the long-term care of the tracheostomy, especially in obese patients, can be difficult. So tracheostomy and other maxillofacial surgery approaches are reserved for patients with life-threatening arrhythmias or severe disability who have not responded to conservative therapies like CPAP. Okay. Another treatment is hypoglossal nerve stimulation. Hypoglossal nerve stimulation can be used as an option for select patients who do not respond to CPAP and have certain anatomic features, including non-concentric airway collapse. A 5-year follow-up study showed improvement in sleepiness, quality of life, and respiratory outcomes in the treatment of cohort. For patients who are unable or unwilling to use CPAP and who may not be surgical candidates, the H3 receptor antagonist, inverse agonist, pitolisant, okay, pitolisant has been shown to improve sleepiness and fatigue. Full normalization of breathing patterns is not necessarily the therapeutic goal. Is not necessarily the therapeutic goal. A randomized controlled trial of adaptive servoventilation in sleep apnea patients with predominant central apnea and impaired left ventricular ejection fraction reported increased cardiovascular and all-cause mortality in the treatment group. So, sleep apnea, folks, take it seriously, okay? The reason I emphasize this is because sleep apnea can cause a lot of problems. It can cause heart failure, high blood pressure. It can also cause cognitive impairment, even dementia. So take sleep apnea. Your body needs sleep, at least 8 hours a night. And also your not just how many hours you slept, how much oxygen you are giving to your brain, okay? How much oxygen you are giving to, that's very important. That's why get a sleep study and make sure you don't have sleep apnea. And if you have sleep apnea, get a CPAP and use it regularly. I know it's a pain in the neck, but in the long run, it keeps you healthy. It prevents many heart problems, lung problems, kidney problems. And if you need more advice, stop by my clinic and I would be able to prescribe you some sleep study and also to get you a CPAP machine, okay? That's not a problem. So stop by my clinic if you have any questions about sleep apnea, all right? All right, folks, that's about sleep apnea. Please visit our website, www.drpaul.org, and we will see you in the next episode. Thank you.